now. Give me 2 seconds. Yeah, guide. Okay, guys, I'm going to repeat what I just mentioned. So the exam is run over 3 days. It starts on a Wednesday, Thursday, and a Friday. The exam consists of Vivas and clinicals. So the clinical day will be on Thursday, and all the candidates will be in 2 different groups. The first group will start on Wednesday with their Viva. Second day will be their clinical, and the last candidate will finish sometime in the afternoon. And this first group will finish. That's the end of the exam. For section part 2, the second group of people will start on Thursday with their clinicals. The same patients will be there, and that will start sometime in the afternoon. So probably the first candidate will start at, I think, 1 o'clock or 2 o'clock. And the second day, which is Friday, is going to be their Vivas. So I hope that's clear from this perspective. Now, going a little bit deeper, when I say Viva, that will mean every candidate will have 4 stations. Each station has different theme, basically. So the first one would be, it can be anything, because you will be given some different timetable for each specialty and for each candidate. So the first Viva will be 30 minutes. You will have, if you are, for example, starting, so okay, let me put it this way. So you have 4 Vivas. One of the Vivas will be general surgery Viva. Second Viva will be specialty Viva. Your own specialty would be upper GI, colorectal, breast, whatever. Another 30 minutes, and that will consist of 6 scenarios, clinical scenarios. Each scenario is 5 minutes. Once the 5 minutes finish, they will immediately stop you and will give you the next question immediately. The third Viva will be critical care, trauma, and emergency. And again, you will be given 6 scenarios. Each scenario will be 5 minutes. The last Viva will be the academic Viva. They will give you a paper ahead of time, like 30 minutes before the Viva. And then you will be given, I think, 20 minutes to get the Viva, to critique the paper. And then after that's done, you will be given another, I think, I can't remember, maybe 15 minutes for basics of your specialty. So if you are upper GI, for example, you will be told about, for example, asked about the achalasia, what's the pathophysiology of that. You might be asked about the anatomy of the blood supply for the stomach, for example, things like that. All right? That's for the first day. Now, people were confused about how this is run. Is it every like one after the other? No, it doesn't work that way. For example, you start the first set of Viva. Sometime let's make a suggestion, like let's say it's 9 o'clock in the morning. So 9:30 you will finish the first Viva. Typically you get at least 1 hour break, at least 1 hour, 20 minutes. Sometimes you get up to 2 hours break between the first Viva to the second Viva. So you go for the second Viva and get your second Viva. You go out, you go back for the third Viva, another hour or hour and a half between. So typically, if you start at 9 o'clock, probably by 3 o'clock you are done with the whole day. All right. Now going for the second day, which is the clinical, 2 stations only. One station is for general surgery, and the second station is for your specialty. When I say clinical, you will get 1 patient, real patient, or can be an actor, but very likely it's going to be a patient. You will only have chance to ask them and take history only. You don't touch them, you don't examine them. Apparently you can shake their hands, but you don't do anything else, only history. All right. Typically in the clinicals, you get 1 long case, which is 20 minutes, and 2 short cases. Each of them is 10 minutes. Typically exactly the same thing, whether it is general surgery or your specialty. So they can start with the lung. If the patient is available, you will take the history. They will probably cut you off, ask you a few questions. You go back and ask the patient, and then another like 10 minutes for the management plan. That's for 20 minutes for the lung. And then the short cases are exactly the same as the Viva, but it's more clinical and more management wise and stuff like that. So two different short cases. And you will have the same sort of breaks. Like if you start at 9 and finish like 20 to 10, you get another break for at least like 2 hours, maybe more, maybe less. And then you get the other Viva or other clinical, and you're done for the day, and you're done with the whole exam. And vice versa for people who are starting on the second day, like starting the clinicals first. They start in the afternoon, they finish the day around 6 o'clock, and next day they will have their Vivas, and that's it. That's the exam. And typically the results come next week, typically on a Wednesday, on the Thursday or the Thursday. Typically that's how it is. So far, is that clear?
Firas, I've got a quick question, if you don't mind.
Please.
In the Viva for you said the first 4 parts. The general surgery one, is it also 6 clinical scenarios of 5 minutes each?
All of them are the same, yes.
Okay,
apart from the academic Viva is the only different station. So the academic, they will give you the paper ahead of time, 30 minutes ahead of time. You read it, you finish it, and put your own notes and stuff, and you go start the Viva. Once the Viva starts, you will finish critiquing the paper. I honestly can't remember. I think it was 20 minutes or so. You finish that, and at the same station, the examiner who was doing the academic with you will stop asking you, and the other examiner will start asking you about the basics of your specialty.
Okay, thank you.
Yeah, no worries at all. So far, is everyone clear about this?
Yes, I wanted to ask in the clinical day, how many stations?
As I said, two stations only. One station is general surgery. The second station is your specialty. In your case, it's upper GI. Yeah?
Okay. Yeah.
And the clinicals are only 3 cases. One of them is long, 20 minutes. The shorts are 10 and 10. So three clinical scenarios in each station. Is that clear?
Yeah.
Okay, excellent. Right. Now, the advice is on the day, or actually before the day. So once you get to know where the exam is going to be held, in which hotel, the first advice is book the same hotel. Book your room at the same hotel, unless you live in the same city. Now, if your exam starts on a Wednesday, I'll tell you about what I did. And apparently you are free, you can do whatever you like. But my advice was to take the same hotel. My exam was a Wednesday. I took the hotel on a Sunday. So the reason is, or the many reasons that you will face during the exam is, first of all, it's a new place for you. Secondly, you are already stressed. Thirdly, you will not be able to sleep well if you go on the night before the exam. You will definitely go to the exam very, very tired, very exhausted, and sleepless, and you will definitely lose marks because your brain will not be functioning 100% on. All right? So my advice, this advice I have taken from my previous seniors. So I went Sunday, didn't sleep well the first night because it's a new place, new environment, everything was different. Second day, I started to be, to get used to the place. I slept very well. The night before the exam, I stopped studying until I think 2 o'clock in the afternoon, and that's it. I was chilling out, found my friends, went out, talked a bit, and completely, de-stressed, basically. So I went to bed around, I think, 10 o'clock or so, and that's it. Woke up like 4 o'clock for the prayers, came back again to bed, and then woke up again at 7, got ready, and went downstairs to the huddle, the big meeting for everybody. I think that's really helped me. The day when I finished the Viva, I didn't do anything, went back right to the bed. I just had something to eat, prayers, back to the bed. That's it. Again, the second advice is during the first day, both days. Once you finish one station or one Viva and you have like an hour or two, go back to your room. don't stand up with people. You can, of course, again, that's an advice apparently, so you can take the advice, you can just ignore this advice. So what I used to do is finish the first station, go out. If I have some people that I know they are positive thinkers and they have positive energy, I would stand with them. If those people have negative energy, I would not stand with them at all. So what I used to do, I finish up, okay, how did it go for us? Yeah, alhamdulillah, it was good. I did this and that, and that's it. I leave everybody, go up to my room, do whatever I want, drink coffee, pray, eat something, relax a little bit, and then go back to the next station. This is exactly my advice, because I have seen people, and I know somebody who's really a negative person. During my exam, I think it was his third or fourth attempt, and everybody was around him. And when he saw me, oh, Firas, how did it go? I said, alhamdulillah, everything was fine. And then he started talking about, oh, they are racist and they want to fail us. I said, okay, thank you guys, have a good day. I left them straight away. I swear to God, the 4 people who were around him failed the same exam. And it was, I think, second or third for them. So my point here is that don't get to sit or to take time or waste time with people who have, you know, negative energy, basically. So that's my advice so far. Is there any question so far? Any question? Auf, did I miss anything? Is that clear?
Yeah, that's great.
Yeah.
No, that is clear.
Yeah. Because Auf, you told me that the other day you did not have this like introduction.
Yes, no.
Before you went to the exam, and it was completely different. You know.
Yes,
what can you say about this? Yeah, please.
So you know, the exam is a day and a half. In reality, your work is about 2 hours.
Correct.
So
yeah.
half an hour, half an hour, half an hour, half an hour. You go in, it's the speed of light. One question,
True.
second question, third question, bye-bye. Next one. 1, 2, 3. So it's not the whole day. You don't go in at 8 and you're being grilled question after question. No, you have your session. And the breaks that Firas was talking about is not an actual break. It's the group division. So you'll be divided into 3 groups. While your group is in, the other group is out.
Yeah.
And likewise, when the other group is in, you're out. So you roughly get between 45 to an hour and a quarter of a break or waiting period, essentially, during which you can either sit, have a coffee, talk to people. If you know anyone, go to your room and come back. You know, you can even nap. Some people go nap and come back.
That's what I did. Yeah, exactly.
And then the clinical or the long and short cases, those are divided into 2, and again a repetition, and it's roughly the same amount of time, an hour and a half in total. But it's just when your turn comes, and it's the same thing. There will be 2 examiners and a patient sat next to them. So there are 3 people in front of you. In the long case, you'll be talking to the patient, but you will not examine. The patient is an actual patient, usually.
Yeah.
There are some actors, I heard they were there, but I didn't, like my stations had actual patients.
Yeah, same for me as well, yeah.
And they have complex histories. It's not, oh, I've done a hernia, how are you? No.
Yeah.
It's Crohn's, 4 scars, 7 return to theater, God knows what complications. But the questions are simple. So it's a bit of a shock effect. And the thing that a lot of people don't really tell you, you have to do history like you're a medical student.
Yeah.
Not like a consultant, medical student. How are you? What's your name? How old are you? And then please tell me why you're here. And every tiny detail of the history, there are 2 people marking you.
True.
If you forget one thing, they will make a very big point of asking you the one thing you forgot. And then they will make a point, because I had that as a negative of mine. I forgot to ask about something. Both of them wrote a comment about it, that he forgot to ask this.
Yeah.
So when they're asking you for history, that they will not be asking you, you know, this 2-minute history that we do. They want a detailed history that usually shows you higher thinking. So For instance, if you get a breast patient and the history is complex and there's a bit of surgery, you should in theory ask about abdominal surgery, because your higher thinking is thinking, can I do an abdominal flap?
Yeah.
They mark these kind of things. It's just history taking, but it has to be in detail. Drug, past medical, past surgical, gynae. If it's a perineal tear, for instance, they want to know gynae history. If it's anal cancer, they want to know HPV status, that kind of thing.
Yeah.
And then everything else Firas really said. I mean, I did not attend this session with Firas when he did it.
Well, I haven't done it long ago. I haven't done it to the previous group. Yeah. But I was thinking that this is really important to make people aware, like oriented, or in at a peace of mind when they go to the exam and see exactly what I'm talking about.
No, absolutely. Yeah. It's not as lengthy. So your part of the exam is very short.
That's
but
right.
Your day is long because you're part of groups.
Yeah. Exactly. Now, please welcome Abdurrahman. Abdurrahman is my partner in the course. Abdurrahman is a colorectal surgeon in Northeast Hospital near Newcastle. We work next to each other. Anyway, Abdurrahman was one of my, not because you are here, Abdurrahman, but I will say the truth. Abdurrahman was one of the candidates who sat the first part one, when I was doing the coaching as well. He passed his attempt, only the first attempt. And then for part two, he was the best, actually. And mashallah, he passed as well the first time for him. Abdurrahman was one of those candidates who listened immediately to what feedback I have given him. I have grilled him really well when he started. And he showed, like a great improvement and immediate improvement. So I started doing some cases with him, and he really struggled at the beginning how to present his knowledge. He's very knowledgeable, but I used to fail him until he became really the best, quite honestly. And I was so happy for him. He passed the first time. I was really not surprised at all. So alhamdulillah. So now he has been doing this with me since September of last year. So alhamdulillah, all my group, last one and the one before. So I would say at least, last time, the one before, I had at least 20 candidates and 18 passed, whether it was their first, second, third, or fourth attempt. They all passed, alhamdulillah. So last one as well. So most of the candidates passed as well. So we will keep doing the same with you guys, inshallah, until you pass. So it's not only when you sit the exam. Whenever you pass, inshallah. So you will stay with us until you pass. So Abdurrahman, welcome aboard. You can say something if you wish. Welcome
Firas.
Thank you.
Congratulations, guys. Well done. It's a big achievement to pass FRCS Part 1. And the best way to clear past Section 2 is to clear it from the first time.
True.
So, yeah. So I think, I don't know if Firas started to talk about the preparation for the exam or not yet?
Not yet, actually. But I just told him how the day runs, basically.
Yeah. Okay. All right. So I think the best way is to keep practicing.
Yeah.
And we try our best here to help you in the group.
Yeah. Great. Thanks, Abdurrahman. Yeah, go on.
And don't take anything personal here, okay?
Yeah. We will be harsh. I'm telling you from now. We will be really harsh. The harsh we are, the more you will remember your mistakes and you will avoid them next time. I think that's, our aim is to be very constructive and for you to know your mistakes the hard way. You better feel failing here during the practice and not in the exam. So that's the point we are trying to make, myself and Abdurrahman. Abdurrahman really is a soft examiner, I would say, but at points he can be really harsh. My critique can be very harsh, and I think I resemble the real exam. The way I conduct my questioning is typically the same as the exam, and I'm sure Auf and Abdurrahman will agree with this. I've been grilling them for the last how many months already. So they definitely agree with this because the way the exam runs, they will start giving you the scenario and you'll start talking, and then they will interrupt you. Okay, why do you want to do this? Because I want to do 1, 2, 3, 4. Okay, go on. And then you will keep answering the question, and then I'll stop you. Okay, why do you want this and this? And you will answer this and this and this. So that's the way the exam runs, and it's very quick. You need to really be slick. There's no faffing around. You don't need to, especially in the Vivas, you don't really need to think as a medical student or as a registrar even. One point I would like to make is this exam is not, so I would like you to think about it that you are already a consultant, day one consultant, and they're just testing you at that level. It's not that you will pass the exam and then become a consultant. No, you are already a consultant at day one level. Does that make sense? So that's the way you need to think about it. It's not about, not the other way around. So if you have this mindset, you should easily pass the exam. You need to behave as a consultant in the exam. You need to talk like a consultant. You must have that confidence when you talk and answer the questions. So I hope what I'm saying is very clear so that you can achieve very well in the exam. Does anyone have any question? I think we are happy to give some of you some Vivas. I mean, to start with, just a warm up basically, so that you can have the feeling of it. Does anyone have any question?
I have one question. How the course will run? So, are we going to meet like every week, or how does it work?
It depends on availability. Now we need to know who is sitting in September, and who's sitting in February, and who's sitting in May next year, May, June time. So those sitting in September will have more priority in terms of grilling them more. Like we'll make them make a start, and then give the others some other questions, and go back to the the other group who's sitting in September. Otherwise, so mainly it's going to be myself and Abdurrahman, and we have another colleague called Mariam. She's not all the time available, but myself and Abdurrahman are more available, I would say. Sometimes if I'm on call or Abdurrahman is on call and I'm available, we will be doing some sessions. Mainly the sessions will run sometime in the evening. If we are on the weekend, we can make a start earlier, like maybe 2 o'clock in the afternoon, maybe 5 o'clock, whatever. But mainly, if during the week, it will likely be after work. After everyone is back, after 5 o'clock, your theater left, whatever it is, we go back, whatever, you need to relax a little bit, and then we can make a start. So that's typical, of this. Sometimes it can be every day. Sometimes it can be like 3, 4 times a week. Sometimes it's every day. Sometimes it's once per weekend. So it depends on availability of everybody. The other thing, that's a good question, Samar, thank you. Sometimes none of us is available. Sometimes I'm available, I'm not available. Abdurrahman is, for example, on call. I'm away, I'm flying. Mariam is not available. So you can do sessions with yourselves, among yourself. What you can do is, one of you can prepare some cases and start, examining others, like you work as an examiner yourself. So Abdurrahman did this to his group when I was away. So he used to be doing this to his colleagues. And I think he had that feeling of the other side of the table. And then, like, he sat himself in the examiner, shoes, basically, as we say. And then that makes a lot of difference. I don't know, Abdurrahman, if you'd like to talk about this experience as being an examiner before you sat the exam itself.
Right, yeah. I think what Sama asked is, as you said, it's very important questions. So the most important thing for this exam to practice. If you come into the course and then we're doing session for 3 hours, and then at the end you do 2 or 3 Viva, and then that's it. It's not the maximum use of the course. So this is more of creating a community. And then if I'm not around, Firas is not around, no other faculty or examiner around, you can do you can do like test yourself, right? And in this group, and if I remember correctly, whoever candidate who gets the initiative to let's guy do the group, let's the guy do the practice, and then you can do like Viva from emergency cases you had in the hospital. You can do Viva from the book. Usually that candidate clear the exam.
Exactly. I 100% agree.
And
yeah.
And then when you ask the questions, maybe it's difficult at the beginning because you don't know how the exam will be run, how the Viva question will be asked in the exam. But once you get that feelings, and then you start test other people, you listen to their answer. Okay, no, I think that's better. And then you revise your knowledge while you testing other people. And then you can create your own scenario. I found that extremely useful. And then I think Firas, when I did my exam in September last year, and then almost 6 weeks before the exam, Firas was not be able to join every day.
Yeah,
and
I was abroad actually. Yeah, I was away.
And he was trying like even to join us for 1 hour or so you can listen and give us a feedback.
Yeah.
So I used to do the course while I'm a candidate, and then we like each and we bear, and then we keep testing each other, right? So keep practicing. The best way is if we could run this every night, but it's not necessarily for the faculty to be here. Whoever is around, who is ever free, they are also a candidate who cleared their exam last May, so they can join us, and then they share their experience.
Yeah.
Okay.
Perfect. Thanks.
But most important to do it to keep doing the practice.
Yeah. Good. Excellent. Any questions, guys? Samar, go on.
Yeah, sorry, I have another question. Sorry,
Please.
I'm being really annoying.
No. Go on.
In part 1, the recalls were really useful. Is it the same case in part 2?
It doesn't work the same way, I can tell you, because in part 1 you have a certain answer that is the correct answer, so you tick it and move on. It doesn't work the same way for part 2. For part 2, you could probably be aware, or you know what case you are going to be examined. And let me give you an example. For example, during the exam, when you are in the waiting area, the other group might have just finished their general surgery Viva, for example. They will come back to the same room, big room, when all the candidates are gathering there, and you are next. So you easily can be told, oh, there's a femoral hernia. Okay, fine. So you will start remembering, oh, okay, fine. How do I do the modified McEvedy, blah, 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 and all that. And you go in, and you will be completely asked completely different questions, but still in the femoral hernia, but completely different questions. Some of the candidates would be asked about how would you assess the patient, for example. The other patient would be asked, okay, you've done this, and how would you do the operation? The third candidate would be asked, okay, femoral hernia, you've done this and that, how would you do small bowel resection, for example? So it doesn't really work the way you think as in part 1. So there's no point like reading old questions. The best thing is practicing old questions or old or previous, exam scenarios. This is the best way to make a difference and to pass the exam easily, because you will have too many different aspects of the exam or the question itself or the scenario. Does that make sense, Samar?
Yeah, understand.
Yeah, perfect. Sumaya, please go on.
Hello. Yeah. So my question is, I've been practicing a little bit with one of my other friends, and I've been using the book, which the Cracking the FRCS.
Yeah.
And we've done it in a question answer format, because obviously it's in a question answer format.
Right.
Is that the book you'd recommend, or would you recommend any other books, or do you think that's for example, for ourselves?
I'll tell you what I did. I'm upper GI, so Sumaya and Samar are upper GI, so you would probably do the same. So what I did is reading preparation wise, I read all the companion book, the upper GI and the emergency. So only the two books. I didn't open the others like vascular, breast, transplant. I didn't touch them. Okay. For the preparation like cracking or stuff, yes, I did the cracking. I did not read it all. I finished, the main and important things like the emergency, the general surgery, and my own, the upper GI thing. And I found that was not enough. So I got the other book, the companion cases book.
Yeah.
All right. And from there, again, I read the same, and I looked at the upper GI bits as well. But I did not look at breast and vascular, and I didn't even touch them at all. That's what I did. And
okay.
it was.
Did you get any Did you get any breast questions or any questions that you hadn't prepared, like an ENT?
Personally, I didn't get any breast questions. But other candidates, they have. I mean, let me tell you this, Sumaya. I'm upper GI. In the upper GI long case, I was expecting to get like a gastric cancer, just tumors, for example, esophageal, Ivor Lewis, and all those things. You can't imagine. My patient was a trauma patient, like a trauma. Oh yeah. I was not well. Okay, I was surprised at the beginning, but
it turned into upper GI.
I don't care. I just did the station, and I got an 8 in that station.
Wow. Okay.
Oh yeah. Alhamdulillah. So by the way, I just go to the marking scheme. How you get the marking? So
thanks.
The marks are between 4 and 8. The pass is 6, just the normal pass. 6. 7 is a good pass. 8 is an excellent pass. Now going to other side of the coin, 5 is a fail, 4 is a serious fail. When I say serious fail, you will be getting, not yourself, like your references and your deanery or whoever signed your references will get notified about this, that you have a serious fail at this topic or at this part of the exam. So that's what I was told, but who cares? I don't know. So, but my understanding is that you get your references to get your results. Basically, that's what I understand. So serious fail can happen. So and remember that you have two people marking you. So the one who's asking the questions, the other one will be marking you, and the other way around. When the other examiner asks you, the other examiner will be marking you. And at the end of that Viva, you will leave the station, and both of them will make a final decision on what they give you. Some examiners will give you, for example, 7 in one particular case or scenario. The other will think, no, I think he did really well, and I would give him 8. Or no, I don't think he did really well, but I would just pass him. I would just give him 6. So eventually, the whole marks will collect and will make you a passing mark out of 600. 600 is the pass mark, and the full mark is 800 apparently. And anything below 600 is a fail, and anything above 600 is a pass, like 600 and above. Yeah, is that clear? Sumaya, is that clear?
Yes.
Yeah, good. Mahmoud, do you have any
thank
questions?
You.
No worries. Mahmoud, do you have any questions at all?
When the session will start and then back-to-back 5 question, is it they will gonna ask us, or you need to read and just answer, or what's the style?
Sorry, what do you mean? What do you mean? Sorry.
Like if you just explain one station how it's running, that would be grateful.
You will have 6 scenarios. Each scenario is 5 minutes. So back to back, 5 minutes. Once the 5 minutes finish, you will be asked the second question, the second scenario. So whatever you have done, you have answered the first scenario. You haven't answered, they don't care. They just jump to the next question. And by the way, the only, like, what can I say? The only fact is when you manage the patient, when you treat the patient, that's the only time you pass the exam, or you pass that particular station or that particular scenario. If you haven't reached the management, you are unlikely to have passed. Very unlikely. Okay, so this is very important. So now you need to train.
That means, sorry to interrupt.
Yeah.
That means so every question answer, there's a structured answer, isn't it?
Not exactly, but there are certain things that when the examiners are very, very experienced. So once they feel that you have reached to where they need you to what you need you to say, they will move on. Like, okay, fine, you've done that, and so what's your next step? I would like to do this and this and this. Okay, you found this and this and that. What's your next step? Just like this. It's very, very
It's just
fast
a
exam.
simple conversation, isn't it? Or we need to learn something
That's an
special.
exact thing. That's the way you perceive the exam. If you perceive it as, oh, I'm a medical student or I'm at an MRCS level, you will feel yourself like you are being tortured. But when you have a mindset that you are a consultant and you're just having a conversation, discussing a patient, this is the time when you pass, and very easily and with very high marks. This is the mindset that I got into the exam, and that's why I passed easily. Abdurrahman agrees with me as well. It will be like a very, very nice colleagues conversation. I think this is the mindset that you need to have once you go into the exam. Do you agree, Abdurrahman?
Yes, Ras, 100%.
Yeah.
You need to speak like a consultant, and it's more of like as if you are discussing a case with your consultant colleague.
True.
Firas, if you let me answer the previous question regarding recalls, I 100% agree with you. Recalls for Section 2 is not useful at all. Because if you count all the surgical topic that you might get tested, it will be like around 50 or 60 topic.
Yeah.
And you will not get the same questions. Regarding the study material, I think personally, it doesn't matter if you decide to go for cracking or companion cases. Just choose one of this book and let that book is your main study material. I use cracking. And then for subspecialty of interest, it's better to read it from both books because you need to master your specialty of interest. It's around 49% of all the exam.
Absolutely.
If you are colorectal, I would highly recommend to go for the website FRCS Viva. I found it extremely useful.
Yeah.
I think we shared some PDF in the group. We can try to resend it again.
Sorry, I
we
missed
will
it.
do.
So what you told? Sorry.
It's FRCS Viva. As I said in the group, guys, if you would like to subscribe to my group, my sessions, you will get some kind of a discount from FRCS Viva. Mr. Siddiqui, he gave me a special code for anyone who joins my course to join his course with, I think it's 15 or 20% off. So I'm happy if you guys would like to, once you subscribe, I'm happy to give you the code for the FRCS Viva. However, we have some questions. I think myself and Abdurrahman, we can test you from there. And it's up to you if you would like to subscribe to them or not. Probably he's been adding some new questions as well, and he asked me to give him some questions of myself.
Your course fee?
Say again, sorry, Mahmoud, I can't hear you.
Yes, just I want to ask, how much is your course fee, and
So
what is your plan, like structure? How you will conduct the.
As we said earlier. So I think there is a code that I have already given you guys, and that will end up £350, and it's only for only one time. You pay it once in a lifetime, and you get out of the group once you pass the exam. Whether it's next September, after 2 years, whenever you pass the exam, that's the time. And this fees is only for that, for this purpose, only to pass the exam.
Okay, that's fair
now,
enough.
Once you get that, I will give you the code for the FRCS Viva to get the code from them as well. To get, to the discounted subscription with. Yeah. Now back to Sumaya. You asked. Yeah, go on, Mahmoud. Sorry.
What will be your style of supporting us? Like what you will do actually?
I'll tell you now. We will make some sessions now. Myself and Abdurrahman will give you the simple things so that you have a feeling of it, and then we'll tell you what's the plan going to be.
Yes.
Yeah, no problem at all. No problem. Now, Sumaya early asked me about the Alpine course. I will tell you my experience with the Alpine, and Abdurrahman is going to give you his experience with the Webs Cross course. what I did, the only reason I got to the Alpine course was because, as I told you earlier, I passed my part 1 in May, and my part 2 was in September. The only reason I got to the Alpine because it was, I think, 2 weeks later of my exam, and I think it was in June, July time. I can't remember. So I got there so that I know what is the exam like. So when I went there, and I got completely deceived because I found out apparently later, once I have passed the exam, that their course is, I would say, at least 60-70% of their material is irrelevant to the exam, completely irrelevant. And I was surprised because they charge you a lot, like, I can't remember, was it 800, 900 pounds? They give you like 4 days of, what do you call it? Like lectures, like spoon feeding. They're not teaching you, like they're telling you this is rectal cancer, this is how it comes, and this is the staging, this is the classification, and you don't need that. This is something that you can study yourself. So this is a waste of time because you will have to take a complete 1 week off completely, because they start at 9 o'clock in the morning and they finish at 5. So that you need off time to take that. And then I think the weekend they do the, if I remember correctly, I think the Thursday, Friday, or no, it's Friday, Saturday, Sunday, they do it face to face. So you go there and you do the Viva. Now, my experience with them is that I wouldn't recommend the Alpine particularly. I don't know about the WIPS course, but I was told it's the same. Alpine, I will tell you my own experience that some of the stations that I was examined was in general surgery, like the examiner told me, okay, can you tell me about sterilization and disinfection? I was like, what? I couldn't do that. Apparently, I told him, well, this is some time from my medical school. You're talking about more than 20 years now. Yeah, tell me what you know. So apparently, I couldn't remember much. So it was only the autoclave. Okay, how much is the temperature? I don't know. How much is this and that? I don't know. Of course, I wouldn't know. And this turned up that it's completely irrelevant because the exam, the real exam, is 100% clinical. There's no faffing around. They cannot give you some subject and to talk about it. There's nothing like this. There's completely nothing like this. So that's what I feel. When I went to other courses, I went to the Christie course. Christie, again, it's good, and I mean, I would recommend it even more than the Alpine because they still give you those lectures and you still have to take some time off. But their style in the exam and the Viva day, I mean, is really good because they are right to the point. Their mock exam is very, very similar to the real exam. There's no faffing around. Christie course, because I passed the first time, the second time I was there as a faculty. They took me as a faculty straight away because I really liked it. Now, there's another course called the Midlands course. Midlands is another course that I recommend very much as well. So again, the first time they ran it, they are mostly my friends. I knew them. They are my seniors. The first time I took it, it was in January, just before my February exam. And it was the best because there's no lectures, no bullshit. Sorry, excuse my language. But only Vivas, only one day. They start at 9, finish at 4 or 5, only Vivas, nothing else. And it is the best. Now I'm still a faculty there, and we are going to run this in July. I can't remember the date, but I can send you the thing on the group. It's going to be run in Stoke-on-Trent, near Manchester. I'm not sure if you guys can make it or not. I'll send you the thing later on today.
Thank you.
And yeah, no problem at all. But I mean, the Alpine is about 850, I think. The WIPS course, I think, is nearly 1,000, 1,200, something like that. I will leave it with Abdurrahman to tell you about his experience with WIPS course. I might be completely wrong.
The prices have all gone up, by the way.
What? Sorry?
The prices have all gone up. So the WIPS, the Alpine is 950. WIPS Cross is like 1,400 for the main one, or like 850 or 900 if you want to be an observer.
But yeah, that's a waste of money. Honestly, it's a waste of money.
I think there is no point to go for a course for observantship.
Yeah, Absolutely.
You will not get benefit from that. So Web's Cross is combination of lecture and Viva. So the lecture, most of the stuff you will get in the lecture is not relevant to the exam. It's very advanced, and you will not get to ask this question in the exam. The Viva is dependent on the examiner. Most of the feedback, they are not realistic. They are very soft in their feedback.
Yeah.
So
being soft in the feedback is not helpful. Yeah, I agree.
Yeah.
Go on, sorry.
And I think overall, it's not necessarily to pass the exam to go for one of the big courses. Yeah. But what can you do? Because I think still people, they will go for the big courses, because the first things I heard from my consultant in the hospital after I passed my section 1, are you going to go for West Cross or albino? So what we used to do here in this group, because there is so many of us, some will go for Christie, some will go for albino, some will go for West Cross or other courses. We used to share this scenario, interesting scenario.
Yeah.
So you can get the maximum benefit. My advice is, don't go for a course that has a lot of lecture. If you decide to go for the course that has a Viva station, because that is the most useful thing to do. Go,
absolutely.
Get grilled, have your feedback, and then that's it. Long lecture is not useful for the exam.
I 100% agree with you, Abdurrahman. I mean, lectures, you don't need lectures. You're not a medical student anymore. You are already a surgeon, and you are there just to hit the target. You get to what you need, and that's it. You pass the exam. You don't really need somebody to feed you or to spoon feed you. Yeah. So would you guys like to have some taste of the exam? I think Mahmoud is so super excited, aren't you?
Yeah, yes, please.
Yeah. Abdurrahman, do you have anything soft to give to Mahmoud? Anything soft? Yeah.
Right. We do it 5 minutes Viva, okay, Mahmoud?
Let's do 5 minutes Viva, Mahmoud. Okay.
No, I think you and Abdurrahman, if you both do this acting, and we'll just.
Oh no.
Man, no.
I mean, we can do that, but that's not gonna help you. You need to be grilled. You need to feel that you are on that chair.
I just want to know how you do the things.
No. We will ask you, and you will get all our feedback, the good points and the bad points. First of all, always what we do, our style, myself and Abdurrahman, once we finish, we ask you how you felt you did. What do you think you have done? You will tell us, oh, I missed this, I missed that, I must have said this, I must have said that, things like that. And then we will give you our feedback. This is how it works.
Okay,
all right.
So I still not.
Don't worry.
Not prepared on that way, to be honest. So
yeah. No.
Anyone
Listen.
can do.
Listen, I'll tell you this.
I think
again.
off can do that, isn't it? Off.
Listen, no, Auf will not do that. And I've done Auf before, so don't worry about Auf. I want you guys to have this feeling, because I'll tell you this. Those people who say, "Oh, I'm not ready. I didn't prepare. Let me just watch." No. What I think the best way is, you need to drop yourself in the sea and try and survive. This is exactly what you need to do. The attitude is different. Now, why I say that Abdurrahman was a good candidate on my course, that he used to say, okay, if nobody is ready, I'm happy to take it. Give me this one, Firas. Please give me the next one. Just like that. This attitude is very, very important. So once you have this attitude, believe me, you will easily pass. All right, go on.
Can I ask a quick question? Sorry to interrupt, Abdurrahman.
Sure.
You know, when Firas was telling us about what he did to study for the exam, what did you do? And did you then just go emergency, Gen.Surg, and then colorectal, because that's your specialty? Or did you look at other texts as well? Did you look at other specialties? Would you mind sharing what you did, please?
Right. So for the Viva book, I study from the cracking. Okay. And then for the colorectal, also I've studied companion cases. I've studied the companion colorectal, and I've tried to cover the emergency and general surgery. I couldn't complete it fully, but I've studied like selective topic. I found for colorectal specifically, because the FRCS Viva website is founded by colorectal surgeons, so there is around 34 scenario for colorectal. If you're not colorectal, unlikely to be to get the maximum benefit of the course of the website. So I found that very useful. Right. And then I came to practice every day in this group, and I have a study partner where we try to cover the curriculum.
Okay, thank you. That's really helpful.
So 6 weeks before the exam, most of the time I've planned my annual leave, so I can be free most of the week. And that's 6 weeks before the exam. Usually I start in the morning. I do some practices with one-to-one, and then some study time, and then on the evening I came to this course, and then we practicing. There is two ways to practice with either study partner or the group. Either you pick a topic, then we're gonna read the critical care, and then we're gonna teach do some Viva station in critical care. This usually doesn't work. I found it more useful just come to the group, because you've been doing surgery for a long time. Most of the station that you see is you're on call or elective theater. Then if you grilled in the topic, so for example, we give a scenario of cecal volvulus, right? And then you haven't performed well in that scenario. So I used to go and read after I've been tested in that scenario.
Okay, that's
everyone
really
studies different. In terms of the courses, I've entered Web's Cross course, and I didn't find it very useful, but it gives you the test of the exam, and then you will get some connection with the people. You see how other people answer the questions. I've done Doctor Academy, and that was 2 week, two night review, like 2 weeks before the exam. I found that it's more of reassurance, like I'm in a good status. In terms of academic Viva, I've done 7 papers to cover each type of paper, like randomized controlled trials, meta-analysis, cohort, and case control. And I used to do it. Sometimes we did once in this group, and one is with my study partner. Academic Viva, I found it is people found it difficult to prepare, but I think it's easy to pass. Either you decide I will do a smart way to prepare for the academic Viva, and then you just pass it, or you cannot care about the academic Viva, which I don't recommend, but you will have to make sure that you're going to score high in the other aspect of the exam.
Thanks, that was really helpful.
There is more tips and tricks. We will talk about it during the course, and how to prepare in the day once you get the curriculum, once you get your station. So from time to time, we'll give you some tips. And honestly, listening what Firas said in terms of feedback, I found that extremely useful for myself. And then in this group, one of the benefits of group study, that you will see how other people answer, and then that way of phrasing the answer is better. I can use that when I answer my questions.
Okay, thank you ever so much. That was really, really helpful.
Thanks.
Thanks, Abdurrahman. By the way, Abdurrahman, because you came a little bit later, I just wanted to let you know that Sumaya and Samar are trainees, upper GI trainees. So Samar is ST7 and Sumaya is ST8. Just for you to be aware of, just before testing them. Yeah.
Oh, okay, good.
Right, Mahmoud, are you ready?
To be honest, I have just zero idea, so I
No
don't
problem.
know.
Come on, Mahmoud, don't worry. Don't worry.
This time.
Mahmoud, will you able to open your camera if you can?
Yes.
Right. Are you what specialty are you?
I'm in colorectal.
All right, my man.
Okay.
There you go.
Right. We'll do
5
something.
minutes, yeah?
5 minutes.
Yeah, I'll take the time. Go on.
You'll take the timer. Thank you. Right. Mr. Mahmoud, you're surgical consultant. You're covering weekend, and your registrar asked you about this CT scan. What do you think about the CT scan?
Okay, so the CT scan is showing this is a contrast scan, axial scan, It could be this is a splenic cyst, most probably.
Right. So radiologists agree with you that is splenic cyst. How do you think this patient will present to the hospital?
This patient can present with sudden upper abdominal pain, and
so
yeah.
how normally splenic cyst will present? As usual, is it usually just abdominal pain, or?
I think they will have a history of background of trauma and then severe pain, or some previous history of trauma. That could be the things. Or
Right. What type of splenic cyst that you know?
It could be simple cyst.
Okay. What else?
And then it could be hydatid cyst.
What else?
It could be hemorrhagic cyst.
Right. What else?
At the moment, I can't remember.
Right. So if I told you this is a 75 years old female that is lying in the gastro ward, and this is an incidental finding, she got some on and off twinges of pain in the left upper quadrant, and the cyst measure 8 centimeter, and they ask you for your surgical advice. What will be your advice?
Okay, so I'd like to see the patient, speak with the patient to take some history. I'd like to do the examination of the patient.
So she's currently in the hospital with hepatitis A, right? She's fit and well, 75 years old. No significant medical history, no smoking history. Examination abdomen is nice and soft. So what would be your recommendation?
Okay, so I would like to have some investigation.
What investigation you would like to know to do?
So we already have CT scan, isn't it? So
yes.
I would like to do an MRI of the spleen.
Why you want an MRI for spleen? What's the benefit of the MRI?
MRI can give exact structure of the cyst, what could be, or
how this was gonna make you make a definitive management plan.
So it can differentiate from the simple cyst with the other type of cyst, like
right. So for example, if you want to differentiate that is hydatid cyst or just simple cyst, how would you do that? Is the MRI useful, or there is other test?
Yes, MRI is also helpful, but we can do the other test.
What other test you're looking for?
I think we'll do the serological test.
Serology can positive for hydatid cyst. A patient is well. What kind of follow-up or plan you will do for this patient?
Okay, so if it's if the thing is hydatid cyst, then it's 8 centimeters. So obviously, my plan would be to completely excise the cyst.
So you will excise the cyst, but you will leave the spleen.
So the spleen is 8 centimeter cyst. On that case, regarding spleen, I'd like to make a plan to do the splenectomy. So it's for the
how
spleen.
How would you do your splenectomy?
So in that case, I will speak with the patient. I will evaluate the patient according to age and then patient's the functional
right. You've done all that. You've done all that.
Time is up.
Question.
Time is up.
It would be laparotomy. Yeah, sorry. Okay.
Right.
So, oh my God.
What do you think, Riyad? What do you think, Mahmoud? Go on.
Oh man. So it's anyways, I don't know. So I just feel puzzled what to do. That's the thing. So is Okay, this is a similar type of scenario and the conversation like this, isn't it? Okay.
I'll
So
tell you my
is,
my feedback first, and then
yes,
Abdurrahman
please,
can give you the rest.
yes.
So of course, I mean, we completely appreciate and understand you have never done this before, and you will definitely learn how to approach and what to say and what not to say. Now apparently the beginning. Now you said too many things about that CT scan. So you said that's a CT, and then axial scan, and then you said scan. So you kept faffing around the same thing. You don't need to waste your time with that. And then what you can say there, that's an axial cut at the level of the liver, for example, and it shows the liver on the left-hand side, and there's what looks like a splenic cyst. Some people would say differently, would say like there is an area of enhancement and an area of thick-walled cyst-like, things like that. Describing a CT scan shouldn't take you more than, I would say, 15 seconds. Shouldn't take you more than this, because actually you don't have enough time. Right? Now, when you were asked about differential diagnosis, you really didn't say what you should say. You started saying, oh, I think this is a simple cyst. Okay, fine. And the examiner kept telling you or asking you, what else, what else, what else? So you always need to take the hint. Like, this means that you have missed so many other differentials. All right. And then when you was asked, what would you like to do next? You did the right thing, that you wanted to see the patient yourself, take re-examine yourself and all that. That's excellent. But next step, you said you wanted to do an MRI scan, and then you was immediately asked, why would you like an MRI scan? How is it going to change your management? You really didn't have an answer, a proper answer. And then he asked you about another test. You still said, I wanted to do the MRI scan. You shouldn't really do that again, because you have been hinted that MRI is not important, is not necessary here. You should really look at something else. Don't say the same thing again. It will not change the outcome. Okay? So he was asking about the serological tests, because this is likely to be a hydatid cyst, because actually he did not mention about hydatid as a differential. And then he has given you the answer. Okay, serology tells you this is hydatid. What would you like to do? I would like to remove it. Don't say that. You need to say more things like, you need to start with medical treatment first, mebendazole, and then you want to discuss this with the ID people, or which are the infectious diseases people, or whatever, medics maybe. And then if that fails medical treatment, then you can discuss the surgical options. 8 centimeters is quite big. However, even if you plan to do surgery for a hydatid cyst in the spleen, you need to give them medical treatment first. That will make the response less. That will give more. You easily can kill the hydatid cyst itself, and will make your surgery easy. So that's my feedback. Abdurrahman, all yours.
Right, Mahmoud, thank you for taking the first scenario. So I'm just going to go through the scenario again in quick way. So for radiology, just go specific. This is axial. I want to confirm patient details. That's not going to get you mark in the exam. Just go for the finding. If you don't know, it's better to skip, say don't know, or you can describe what you see. There is something in the spleen. I want to discuss it with the radiologist. The exam, there is a lot of CT scan, there is a lot of imaging. So while you're preparing for the exam, try to have a folder of the scan, because you'll see a lot of scan. And scenario can start like this. Just the beginning of the scenario, you will have an image, CT scan or MRI scan or even X-ray, right? Now, while you progress in the scenario, don't do this again. Don't mention things that you cannot defend. I know sometimes you get stressed. It makes logical that is, so for the liver, for example, we need 2 modality. Either we do ultrasound CT or we do CT triphasic and we do MRI. So in the exam, don't mention things that you cannot defend, because the examiner will stop and then will keep asking you about this thing you mentioned, right? So I've tried to give you some hint to progress in the scenario and this prompting. So prompting the exam will get out of your mark. Okay.
Yeah. Thank you very much. Yes.
Splenic cyst and liver cyst is very common scenario. It came in my exam September last year, and it came in May last year as well. Okay.
Excellent. Well done, Mahmoud. I mean, I'm glad that you was brave enough to take the first trial here, which is great. Who would like to take the next one?
Can I ask a question?
Sumaya, go on, please.
So when I was looking at that scan, I think my brain just went completely to mush, thinking, is it related to the stomach? And I really didn't know. And so well done, Mahmoud, for actually getting the fact that it was a splenic cyst.
Yeah.
And I guess now that you've mentioned it, I'm like, oh yeah, it's obviously where the spleen would be, and it's a big.
Yeah, you can see the stomach in between, like spleen and liver. There is the duodenum most probably.
Is that the spleen being
duodenum or
in the liver?
stomach most probably there in between.
There. Okay, thanks.
Yeah.
I guess Abdurrahman, you said if you don't know, just say I don't know. Yeah. But then that's where everything stops, isn't it?
No, I'll tell you this. What's the escape policy here or strategy? You need to say that I cannot really tell what I can see, what pathology I can see, but I would like to look at different cuts, and I would like to speak to the radiologist to get a formal report. This is how you escape your struggle here. Yeah. Absolutely. Because believe me, Sumaya, you don't have time. You wouldn't have time. You really need an answer. They will tell you, okay, the radiologist told you this is 1, 2, 3. What would you like to do next?
Yeah.
Because this is not a radiology exam. It's a surgery exam.
Yes, exactly.
Yeah?
Yeah.
So, yeah.
Thanks so much. That's really helpful.
Oh, no problem. No problem. Like, who would like to take the next one? So, Maya, are you happy to take the next one?
Go on then.
All right, Abdurrahman, I will give her one scenario.
No problem. I'll get the timer. 5 or 10 minutes.
What do you think? Right. So we can make it as a 5 minutes.
Thanks.
But I think for the sake of the discussion, it will go longer.
Okay.
Right.
Okay. So right. Sumaya, so you are the surgical consultant. You've got, how do I put it? So you've got an elective list on a Friday, and you have so many admins to do and letters and stuff like that. You wanted to finish, and it's actually the last patient you would like done.
Mm-hmm.
You have an ST7, very good registrar of yours. Very, very skilled and reliable and all that. So you asked him, oh, can you please come and do the last patient? He asks you, what's the last patient? You tell him that it's a 78 years old gentleman with a right inguinal hernia, recurrent hernia, and the patient has had ischemic heart disease, and he was on clopidogrel that was stopped about 5 days ago. 7 days ago rather. Mm-hmm. And he's been optimized because he had some problems with his hearts and lungs and stuff like that. So he had all the CPECs and all those things. He agrees. He said, okay, fine, I'm happy to go and do it. So you left, you went to your office, started doing your admins, and then half an hour later you got a call from the sister in theaters. Was very anxious. Dr. Sumaya or Miss Sumaya, would you like? There's a problem here. You ask what happened. They tell you that your registrar opened the left side. What would you do now on the phone? What would you do? The time starts now. Go on.
Okay, so this is obviously a never event because it's the wrong side inguinal hernia. I'd say on the phone, okay, just stop for the minute. I'm going to come straight downstairs. I'd go straight down to theatre. I'd assess the situation. I would ask how far he's got, because obviously if he's started and he's just opened the skin, then...
He only opened the skin.
Okay, so I think from that point, I would close the skin. I'll get him to close the skin while I do the right-sided inguinal hernia repair.
Let me stop you here. The moment you arrived to theaters, everyone is in shock. Your registrar is sweating and shaky.
Okay. Yeah.
Everyone is angry. What would you do at that point of time when you reach the theater?
So I think this is a different situation to what I was obviously expecting, and obviously it's a very serious situation, and nobody's in their right mind to continue, as far as I'm concerned. So I would ask the registrar to step out, just sit down, have a, get some water. I would explain to the team that I'm going to close the skin, and I think what we should do is probably pause, because in fact stop the operation after I've closed the skin, because I don't think people are in their right mind if they're not I don't think it's a safe situation to continue, as another event has occurred, but it's a sort of, what's the word, where they've just opened the skin, they haven't done any further damage, so technically it shouldn't have happened, but we haven't caused more harm, if you see what I mean. I've paused there. So that's probably what I would do in that situation.
So you decide not to operate on the correct side. So you'll just close the skin and wake the patient up, right?
I think so in this situation, because if the anaesthetic team are all upset, if the theatre staff are all upset, then it's not the right situation to continue.
Have you asked them? Did you ask them?
That's what I mean. Like, if you said that I've come downstairs and they're all in shock, I think what I will do then is, if I haven't done it already, speak to the sister in charge and just say, right, let's have an update of what's happened, and then ask everyone in theatre, would they want to continue or do they want to stop?
It's your decision. It's your decision.
Okay, then I'd make a judgment call, and I think with my anaesthetic consultant colleague, I would see whether they would want to continue, and if they say yes, then I would probably continue and do the repair on the right hand side.
What would you recommend? What would you recommend?
I would say yes, because this patient has stopped his clopidogrel. He's a high risk patient. It needs to be done. There's a reason he's on this list. And I think if I'm comfortable to do the operation, and the anaesthetic consultant is happy and the scrub nurse is happy, so that's 3 people, then I would continue to do the operation.
Fine. Okay. Let's assume that you have done the operation and you finished. Now the patient is in the recovery, having his tea and toast. What would you go and tell him?
So I would go and speak to him, and I would explain that actually there had been an error. I'd explain, first of all, we have a duty of candor, essentially, to speak to the patient and explain what's happened. And I would apologize for the mistake that's happened, but I'd also explain that we stopped after we realized once we'd opened the skin, so we've repaired that, and I've done the operation on the right hand side, and I've repaired his hernia, which is the main thing he came in for.
Right. Talk to me. I'm the patient.
Okay. Mr. Smith, I just wanted to explain. There's been an error that's been made in the operating room. However, and the error was that my registrar started the operation and actually went into the wrong, operated on the wrong side. He operated on the right.
So you haven't done the operation as you told me.
No, I have done. I came down and I've done the operation on the correct side, but you do have 2 scars. One is the left side, which is the incorrect side, but that's a skin incision and a scar of the skin. But I've done the repair for the right hand side, and I'm really, really sorry that this is happening.
But you made this mistake. You asked someone else to operate on me. I'm not happy, doctor.
I understand that, and you are able to put in a complaint, and I'll give you all the details for the PALS department, and I'm sorry that this is a teaching hospital. I have a very, very senior registrar with me who has done many of these operations, so I didn't have any doubt in his ability to do this.
Can I have his name? Can I have your registrar's name? I would like to make a complaint against him in the GMC.
Yeah, that's no problem at all. I'll speak to my registrar and we'll do that for you.
No, I want his name now.
Okay, it's Mr. El-Hanafi.
I don't do that. Okay, fine. Let's assume you've done that. What else would you like to do? So the patient is okay with that. So
the other thing is I would put
5 minutes is up.
5 minutes is up.
Thank you.
Yeah. What do you think?
I think you probably could have been a bit smoother. I think I didn't know where you were going with this. You see, that's the other thing. So when I came to the wrong site operation, I was like, shit, okay. But in terms of, I was like, right, this is an event, but then I was like, it's a serious event. It's happened, but I feel like it's one of those, it's a serious incident, because we've operated on the wrong side, but we haven't done further damage. We've sort of rectified it quite early on, but I don't know. I'm a bit vague about the exact, would this be classified as a never event? Because we stopped it once we realized. So it's a serious incident and it's a near miss, isn't it? Because it could have gone further and been a completely wrong operation. But
true.
I guess it is a never event because we've cut the skin, haven't we? I mean,
of course, yeah.
And then the other part was, was that when you were asking about doing the operation, reading the room, this, that, and the other, I have been in situations where we've had a real horrible thing happen and the consultant has not been in the right mind to continue. We've just stopped, obviously, okay, or paused things.
But you need justification for this. It's not right or wrong decision. You need to have a decision, and you should have stick to it. Exactly. So you've been what do I call it? Like shake. I've shaken you basically. Like when I told you, oh, would you operate? Okay, so you actually did the right thing by operating on the patient, because the justification is that you correctly said that this patient was in clopidogrel and it's been stopped. The patient was optimized, blah, blah, blah.
Yes.
That's definitely the right thing to say.
Yeah.
If you chose to operate on the patient.
Yeah.
And if you don't choose to operate on the patient, that is a different discussion. I don't know what is the right thing to say when you don't operate on the patient. You need to have a justification for that.
Yes. Yeah.
Right?
I mean, yeah, definitely. And most of the time for us is that when we've had to cancel people for an operation or wake them up is because something bad's happened, like they became bradycardic or they're
of course
logically unwell to do it. Yeah.
Right. Now, you've done the right thing by talking to the patient, and the way you said that duty of candor, probably more questions could have gone like, what is duty of candor? What are the principles of duty of candor? You will definitely get a duty of candor case in the exam. Definitely, you will get one. Either like the whole scenario would be about it, or partly like this.
Okay.
All right. Now,
I need to learn it.
Right, yeah. Something else you said that you, or actually the wrong thing that you did is that you have given the name of your registrar.
That's true. I didn't know what to do.
Yeah, I'll tell you what to do. So what you should have avoided is the name and actually the way you pronounce the problem. You should say passively, like a problem has happened or a mistake has happened.
Okay.
You cannot say my registrar did this, my assistant did that. Don't point fingers to anybody.
Okay.
All right, that's very important, so that you don't put anyone in trouble. Now you will put me in trouble. You will put your registrar in trouble. Now your registrar will have lots of disciplinary actions. He will go to reflection and probably problem in their ARCP and all those things, isn't it? Yeah. So you have put your registrar in trouble, which you shouldn't. All right. You should be supportive to your registrar. You should tell the patient that you are responsible.
Yeah.
And it's your responsibility and you will take it on your shoulder.
Yeah.
Now, second thing, the scenario would have gone to apparently the never event or the incident report that you should have done and the investigation that you should run yourself, or at least partly you should be part of it. Third point or third part of the scenario is talking to the registrar in a sympathetic way. And then see how they reflect.
Okay.
Whether they have insight or they don't have insight. If they have insight, they will be apologetic and I'm sorry, I haven't done this, I haven't done that, and it was probably, you need to investigate the root problem of this, isn't it?
Okay. Yes.
How did this mistake happen? Is it is the WHO checklist done? Yes or not? Now, was there a mark? Yes or no?
Yeah.
What was the problem? The registrar would have told you, oh, I mean, if you continued, apparently.
Yes.
So, the registrar would have told you, oh, I just went to scrub and I came back and the nurse just applied the drapes on the wrong side.
Yeah, that's
not
often
really his problem. I mean, it is his problem, apparently, but this is how he was deceived.
Yes,
right?
Yeah, definitely.
If they don't have insight, like they will tell you, oh, it's not my problem. He just asked me to go and operate. It's not my problem. And you look at his previous history and his previous ARCPs, then you need to speak to their educational supervisor, and it can reach to the GMC.
Yes.
And
Yeah.
the fourth component of this scenario is you need to finalize your investigations and
Yeah.
write to your patient.
Okay.
You either write to them, not either, you have to write to them and
Yeah.
or bring them to the clinic to
Yeah.
facially do it.
Yes. Yeah.
That's the whole scenario. If you reach there, you get an 8.
Okay.
Easy.
Thanks. Thanks.
Yeah.
That's really helpful for us.
Yeah,
So the last part where you said you have to write the letter.
Yeah.
When we bring them to clinic, is that when you give them the letter?
No, when you get this the what do you call it? To
Report,
finalize the finalized investigation. Yeah.
Yes. Yeah.
You
Right
need
to
to
your patient with that
involve
result.
them that this is
Yeah.
what we found and we
Yeah.
apologize and this is what we can do for you, and that you basically do a duty of candor in the letter.
Yes.
That's what we can do for you, and if things can happen in the wrong side, we can treat it with this and that. Things like that. So that's
Okay.
part of a consultant mindset, isn't it?
Yeah, thank you. That's really helpful. And sorry for throwing you under the bus.
Oh, no, exactly. But well done, well done. I mean, I think I would pass you in this one, but you actually haven't reached the final management of the patient, so probably it's a 5 maybe here, not really 6. Yeah.
Yeah. Okay. Thank you so much. Cheers.
No worries at all. No worries at all. Who's next? Summer.
Sorry, Firas.
Yeah. Go on, Abdurrahman.
I think in the previous scenario, there is a good thing. She used the right buzzword. She started the scenario by saying never event, and she mentioned duty of candor. I would think she will pass the scenario until she spoken to the patient and she mentioned the registrar name with
exactly.
Yeah, so I think 5 will be fair in this scenario.
I agree. I think Sumaya will agree as well.
Definitely. Thank you.
No problem at all. All right, who's next? Who's ready? Summer, come on.
Yeah, let's go.
Go on, Abdurrahman. Do you have anything for her? She's upper GI, but give her something general if you wish.
Okay.
Or you know what? Can you give her that case, the one you gave 2 days ago to someone?
Text me which case.
I'll text you. I'll text you in 1 second. Sorry, guys. Give me 2 seconds. I'll find you. Got it, Abdurrahman?
Yes. Okay.
Thank you.
Give me 1 minute just to allocate where the scan.
Yeah.
Right. Firas, feel free if you want to jump and take over in the middle of the scenario, okay?
Yeah, of course.
Right. Sama, your surgical consultant call on Saturday. Your registrar admitted a 55-year-old female that had a gastric bypass done abroad outside UK for weight loss. She came in with severe abdominal pain, vomiting, and she looked unwell. How would you approach this patient?
I would like to take a history from the patient, including when was the surgery and when exactly the surgery was, and examine the patient, get some bloods, and get a CT.
Right. Okay. So in the history that she had gastric bypass, as I mentioned 2 years ago. Otherwise, she had type 2 diabetes. Examination, she's diffusely tender. Heart rate is 99. Blood pressure is 90/50, and respiratory is 24. Do you still want to go for CT scan?
No, I would like to resuscitate the patient first. she's not fit to go for a CT at this stage.
Right.
So,
Okay. So what you want to do?
right. So initially, I'll keep the patient nail by mouth. I'll give her IV fluids. Also, I'll get some bloods, and it's she vomiting.
Yeah, I mentioned the question. She's vomiting.
Right. So I would insert an NG tube. She had a gastric bypass 2 years ago. So I'm suspecting she might have some sort of internal herniation.
Right. What
causing
other
bowel
differential
obstruction.
diagnosis come in your mind apart from the internal hernia?
Also could be adhesional bowel obstruction.
What else?
She's type 2 diabetes. Had the diabetes resolved after her surgery?
It's improved, and now she is in get only metformin.
Right. And her BM now, is it okay?
I'm asking you about the other differential.
Of her abdominal pain. So if she's got very high blood sugar, I would suspect DKA as well can cause
What
her
else?
abdominal pain.
What else? Any
Abdominal
other differential?
pain, vomiting. She could have anastomosis ulcer that has perforated.
What's the name of that ulcer? And
I can't
in which
remember.
anastomosis?
I can't remember. It's the Gen.Surg.
Right. Okay. So patient responded to your resuscitation. The blood workup show white blood cell of 13.5, CRP is 85, UNE is GFR of 75, which is normally she's above 90. What else you want to do?
Yeah, I would do a CT scan.
Right. So this is a section of her CT scan. Tell me what you can see.
Mm-hmm. I can see free air in her abdomen. Thickened small bowel loops. Distended
Right.
thickened small bowel loops and free air in the abdomen. So there's some sort of upper GI perforation going on. Also, I can see swirl in the middle.
Right. Okay. What swirl sign indicate?
Indicate internal herniation.
Right. How would you manage this patient?
She needs a laparotomy.
Right. How would you prepare this patient for laparotomy?
So she's got an NG. She needs a catheter.
You
fluids.
told me earlier you don't want to insert an NG, right?
No, I said I would insert an NG if she's vomiting.
You said that. Okay.
Yeah.
I thought you said at the beginning you want to do that because she had a bypass.
No, I would do NG, urinary catheter, IV fluids, IV antibiotics. Inform the anesthetist, inform theater, get a group and save, and get the rest of her former bloods. Explain everything to the patient and consent her.
What you will put in your consent form?
Right, so I'll consent the patient for laparotomy plus proceed, including bowel resection.
Are you going to do the operation by yourself, or do you want someone to help you?
I can start operation myself. I'm upper GI surgeon, and I'll have my assistant with me.
Right. Okay. Take me through the operation. How would you approach this patient?
Right. So I'll do upper midline laparotomy.
Mm-hmm.
Do sepsis control. So do proper washout because this patient probably perforated.
What is sepsis control?
So I'll do a proper washout, identify where is the perforation.
How would you identify where is the perforation?
So I'll start examining, starting from the stomach, going downwards.
Right. How would, if the patient had a gastric bypass, how would you start from the stomach?
So from the Gen.Surg.
From the Gen.Surg. Right. Okay. So we suspect this patient has internal hernia. Can you tell me where is the side of the internal hernia?
That probably will be in the through the defect of the mesocolon.
Right. Do you know the name of the defect? How many defects you will expect after gastric bypass?
So this is the main one that I can get hernia in. I don't know the names.
You
Can't
don't know the
remember
name.
any now.
How many defects?
Where is that hole? Sorry, Abdurrahman, I'll take over. Where are those defects, or how many defects would you expect in patient post through NY gastric bypass?
Okay, you're asking me difficult question, but anyway,
No, you're upper GI
the one,
surgeon. You're an upper GI
yes,
surgeon. Yeah.
yes. So the defect I'm thinking about, the main one, is the one through the mesocolon of the transverse colon.
Do you think that's a normal? I mean, it's a defect that is normally created during the NY gastric bypass. Is that what you're trying to tell?
Yes,
it?
and we usually close it afterwards. But
how do you close it? If so, how would you create that defect? Why would there be a defect in the transverse mesocolon in a patient with a Roux-en-Y gastric bypass?
this is to feed.
Let me put the question in
efferent
another way.
limb.
Let me put the question in another way. When you perform a Roux-en-Y gastric bypass, do you normally make a defect in the transverse mesocolon?
That's what I remember.
Right. So you do it. What do you do it for?
It's to feed the limb through it, the small bowel limb through it, and anastomose it to the stomach.
Right. Which limb? How many limbs do you have in the Roux-en-Y gastric bypass?
Two, afferent and efferent.
No, afferent and efferent. They have different names.
The elementary limb.
Alimentary limb. Okay.
Yeah.
Alimentary limb is the Roux limb. What's the other limb called?
The biliary.
Biliopancreatic. So so you pass the alimentary limb through the transverse mesocolon. Is that what you're telling me?
Yeah, that's what I think.
Okay, fine. So that's the only defect you think that can happen. So if you say that you close it, what do you mean by that? So you create it, you pass the Roux limb through it, right?
Yeah.
And then what do you mean by you close it? How do you close it? Or
so if there is a wide defect that can allow other small bowel to herniate through, we usually approximate it with
you mean you just
stitches.
approximate it or narrow it just to be enough for the Roux limb to pass, right?
Yes.
All right. Okay, fine. Fair enough. What are the other defects? Or do you know of any other defects?
I can't remember.
Right. Okay, fine. So in this patient, during your laparotomy, you haven't found any perforation, no pus, nothing. So you found that the anatomy is really altered. You couldn't really tell which one is the Roux limb, which one is the biliopancreatic limb, and there is like a defect between the jejunogenostomy at the jejunogenostomy area and the mesentery, and you cannot tell whether the bowel is really herniating from the right side or the left side. How would you make a decision during this operation? What would you do?
I would run the bowel.
Where would you start? Where would you start from?
Start from the GJ.
The GJ.
GJ.
Right, GJ. The GJ. So that will take you to the transverse mesocolon, as you described earlier.
Yeah.
And then after that, where would it go? It's very mixed up between the bowels that stuck in the hernia and the rest, so you cannot really tell and follow. What would you do?
I can start the other way then.
What's the other way?
From TI.
TI. That's actually the only way you start from.
Yeah.
So you start backwards. So what do you call that limb, the one from the TI? What do you call that one?
That's the elementary one.
No. The TI.
That'll be the ilium, right?
No, it's called the common limb, because that will connect the Roux limb with the biliopancreatic limb and make the common limb, right?
Yeah.
Right. Let's stop here. I mean, Abdurrahman, do you have any other questions, or is that it from your end?
No, I think that's it.
Okay. Okay. Samar, what do you think?
I'm very confused about the anatomy. I think that was my main weakness.
Well, it's not really good. Doesn't look right, Summer. You are an upper GI.
No.
There's no excuse. No
No.
excuse. I'm disappointed, quite honestly. You really need much grilling. I will be grilling you properly until you pass the exam, inshallah. Okay. So, Summer, it's not acceptable at all that you are an upper GI trainee, ST7. You're soon becoming an ST8, inshallah. You should be finishing your exam. This is not an excuse. This is a very easy scenario. You will likely get in one of your Vivas. Basically, likely you will get it in your specialty Viva. You can also get it as an emergency, and you also can get it as a general surgery. So you will likely get this scenario. So this is a very easy scenario. Now I will tell you about your approach in the beginning. You definitely did the wrong statement, long landing statement. So you've been told about the history of the patient, and you didn't pay much attention about the details of the question. You did not get to know about the vomiting. You did not really pay attention to that because you asked the examiner again whether she's vomiting or not. You've been told the patient had the Roux-en-Y gastric bypass 3 years ago. You still wanted to know from the patient how long the patient had the surgery. Also, you've been told the patient had a Roux-en-Y gastric bypass. You still wanted to ask the patient what kind of surgery the patient had. This is completely unacceptable. All right. Now, secondly, you immediately wanted to do a CT scan. This is completely the wrong answer. Okay. Of course, eventually you will need a CT scan. However, you need to resuscitate the patient first, according to the CRISP protocol. That is almost always the landing statement. Nothing else. Okay? Especially if it is an emergency, and this is an emergency patient. Patient has got an internal hernia, has been vomiting, severe abdominal pain, low blood pressure, tachycardia. What else do you want? Do you really want to take the patient for CT scan? That's a fail already. You have already failed the station at the beginning, at the first sentence you have said. You have already failed. All right? So the further questions are only, as an examiner, as an experienced examiner, myself and Abdurrahman, we only continued just to have a good fail, to give you a good fail. Like we prove it that you really fail. You see what I mean, Samar?
Yep.
Yeah?
Yeah.
So at the beginning, every patient with becoming unwell, NED, you always need to resuscitate them. That's the first sentence you need to say, according to the CRISP protocol. That's it. If you say this, you're done. They will not need any further, information from you. They will tell you, okay, you've done that, and then they will move on. All right. If you haven't said it, they will grill you in that one. You haven't done the resuscitation. Why would you want to give antibiotics? Why not giving fluid? They will grill you properly. All right. Remember the word protocol and sepsis 6. I don't think you will be asked about what is sepsis 6 or what is CRISP protocol. I don't think they have time for this, because if they ask you about this, this means you probably have already failed and they're just wasting the time, the 5 minutes, I think. All right. So that's one thing. Other part is that you would like to take this patient for a laparotomy. And when you get a question from the examiner that would you operate on your own? My advice to you, Samar, and everyone here, take the hint. This is a hint question. This is a prompting question. This means that something is not right. I have probably said something not right. I should not really take the patient on my own. The reason behind this, why am I asking you or telling you this is a bariatric operation. Okay, you are an upper GI surgeon and you are an upper GI trainee and all that. However, you always have to mention that you need to discuss this with a bariatric surgeon in your hospital, or call the nearest, bariatric center or unit for an advice. Okay, right. I'll tell you this. I got this question in my Viva exam, in my special interest, 5 minutes Viva. So I reached to this point. I apparently resuscitated the patient. I already told them what defects they normally have. 3 defects, actually 2 defects. And the one you described is completely obsolete. Apart from some people, Kelvin Higa, the one from California, he does it, and that's named after his name. doing the retrocolic gastrojejunostomy. That's not really done. That's not the routine. You always go anticolic. All right. So you really need to know the anatomy very well. You get the Peterson defect, which is between the root limb and the transverse mesocolon, or the transverse colon, and you always close that bit. The second one is the jejunostomy. You get another defect there, and you close it. All right. So these are the potential defects. If you do the retrocolic, yeah, that's a third one that is possible. All right. So what I was told is to they have like a drawing there. So I have to point. This is Peterson defect. This is JJ, and this is the possible retrocolic, and that's the Kelvin-Hegel's method or whatever technique. Right. After that, how would you manage this patient? Is this patient needs full resuscitation and needs to go to theater. However, I need to speak to the bariatric colleagues. And then actually, I didn't say this in my exam, and then they immediately prompted me because I was very good at the beginning, and then they prompted me, would you do this yourself? I said, well, I took the hint immediately, Samar. I immediately took the hint, like, oh, okay, fine. I'm actually trained bariatric surgeon. I've done this so many times. However, because I took the hint, this is how I'm going to change my answer in a nice way, right? So I said, if my hospital doesn't have enough, not enough, like the settings for bariatric, like ITU, the instruments and the trained nurses, the bed and all that, I will definitely speak to the bariatric colleagues in different hospitals. And then at that point, they were happy about my answer, and they asked me, what do you think needs doing? So I told them I need to go diagnostic laparoscopy to find out the defect. I will run the bowel from the TI backwards at the common limb, and then find the common channel, basically. Sorry, and then I'll know which one what is what. Which one is the BP limb? Which one is the root limb? And then reduce the hernia and then close the defects. And that was it. I passed that, and I got a 7 in that one because actually I didn't say bariatric colleagues at the beginning. But for you, you definitely failed this station, I'm afraid. Okay, does that make sense, Samar?
Okay.
Yeah?
Yeah, it does.
Yeah. Abdurrahman, do you have anything to say? And I'm sure Sumaya will have something to say as well. Abdurrahman, go on, please.
Right. Okay. So you will hear this a lot in when we do the Viva. You should have like write this landing statement or opening statement, right? So I used to do this. I thought, like, my concern in this patient is internal hernia. I will approach this patient according to the CRISP algorithm, make sure that he's adequately resuscitated. And then I would like to take a focus history, examine the patient, and do appropriate blood. So you can say that sentence in 15, 20 seconds, right? And you will get control of the station.
Okay.
Right? Then don't mention CT before doing the blood, before they examine the patient. They like the order of history, examination, bloods, and then you do the investigation. It's not a good technique in the exam to ask the examiner question. So you have a wide differential diagnosis. I don't know why you mentioned DK as number 3 or 4.
Oh yeah.
You can say in a smart way, the common is internal hernia. I'm worried of other differential, which is include marginal ulcer and other differential of upper abdominal pain, such as pancreatitis, cholecystitis,
appendicitis,
pancreatitis, ischemic bowel, and then there is also a medical cause. Right? You will not get a point by asking what is his PM. That is a very poor technique in the
very
exam.
poor technique, exactly. Yeah.
Right. And remember, Sama, this is a consultant exam. So when I ask you how would you prepare this patient, I won't expect you to say a catheter and NG tube and IV fluids and stuff like that. So whenever you prepare patient in theater, remember 3 things. You want to speak to the patient, you want to speak to anesthetist, and you want to calculate the needle score.
Yes.
So, and then don't answer like a small sentence, this patient needs laparotomy, and both. Sometimes both is a good technique in the exam, so you can wait for the examiner to give you more question or give you a prompting if you don't know what to say. But when you reach the management, that should be automatically in your mind. So you say the buzzword here, this patient needs an operation, this patient needs a laparotomy. I would like to speak to my anesthetic colleague. I want to calculate his NELA score, and I want to consent the patient. This patient is bariatric procedure. I would prefer to speak to bariatric center. However, if he's unwell, it's my responsibility as emergency surgeon to take this patient to theater. That's one way to phrase it, or you can phrase it in as Firas mentioned. So there is no right or wrong as long as you mention the right stuff in a very nice way.
True.
Right?
And by the way, it's not a wrong answer to say laparotomy. Absolutely not a wrong answer, because if even this case can come to one of the transplant surgeons, for example, or breast candidates, all right? It's not wrong to say, I would like to do a laparotomy for this patient, because you probably are not trained as a laparoscopic surgeon, or you probably don't know the anatomy of the Roux-en-Y gastric bypass, which is actually not an excuse, but it is not a wrong answer. But as an upper GI surgeon, you must have had some rotations in bariatrics. It is at least expected that you would like to do a diagnostic laparoscopy at the beginning, with a chance to convert to a laparotomy and proceed. At least you need to put that in your consent and in your discussion as well.
And also, Sama, one of the important things in the exam is how to present yourself. So the way that you present your answer, I didn't feel you're confident.
No.
So you need to really act like a consultant. Okay, so your voice should be more confident when you say your answer.
Yeah, and the style as well, Samar, it's not like part one. It's not like one answer and you pause. No, you need to keep talking. Like, I would like to take this. I think the differential here, as Abdurrahman quite rightly said, that you can make it like in two categories. Like, I think something related to the surgery, surgical differentials, and probably some medical conditions as well, right? So you need to mention about internal hernia, marginal ulcerations, and acute cholecystitis, pancreatitis, appendicitis, small bowel obstruction, adhesion, anything. You mention all those, and then you could probably mention some medical issues as well, but don't put them on the front page, basically. All right, this is a surgical exam, remember this, and they don't really care about medical issues. Actually, they don't know what are the possible medical problems, but actually you can mention it, but at the end of your answer, not at the beginning of your answer, if that makes sense. Yeah. Excellent. Sumaya, you wanted to say something. Sorry.
I wanted to ask actually a question. So when you asked me for my scenario, I wrote it down as you were talking. Okay. In the exam, do we have pen and paper? Are you sat down or are we standing up?
No. You're sat down. You have a glass of water. You are very calm. They're making you calm, actually.
Okay. That's good.
Yes, and remember, the aim of the examiners is to pass you, not only just to grill you, or it's just like to pass you. And yes, you do have a pencil and a group of papers. You can make some notes. The way good that you raised this question, that you need to understand the situation there, that yes, you have a pen and paper. And the way I was teaching people in previous groups, what you need to do is that exactly like when you take a referral from A&E. What do you normally do? You still have the list in your hand. You have the list in your pocket. You take it out and you look at the back, and empty place or space to write down, isn't it? This is exactly what I've been telling people, and this is exactly what I have done in my own exam. Like, the very, very important and relevant information: patient age, male or female. Presentation, you just write RIF, like right iliac fossa, and then you write about the tenderness, yes or no, and then background. They probably will tell you in the A&E referrals that this patient had colon resection 7 years ago for cancer, and now the stoma is bleeding, things like that. You need to like very, very tiny buzzwords, you need to write them down so that you can remember. Because as Abdurrahman rightly said to Samar, it's not a good technique to ask the examiners any questions. This is really, really bad. All right. This will tell them that you are not listening, you were not listening. And that means also to them that, you don't know what you're talking about. Which is really a very bad sign. Okay. You probably will be very lucky if you pass that station. if you do it this way. All right.
So
Yeah.
the reason I mentioned it is because Samar, did you write any of that down at the beginning? Because in his first line, he said 55-year-old female, gastric bypass 2 years ago, vomiting and unwell, and
Yeah.
that's the. I don't know if you'd, and if you've written it down.
I haven't written anything.
Yeah.
Okay.
That's yeah.
Yeah, because
Go on, Sumaya.
those words are literally for me the trigger to go. This is an unwell patient. I need to approach the patient in a crisp protocol with thinking about sepsis 6, and
Exactly.
these are the buzzwords they like, and it's the
Yeah.
first thing you can get out, and it's within like 10 seconds, you know.
Yeah.
But thanks for clarifying that for us, because
No.
absolutely.
Absolutely. No, absolutely. Samar, yeah, please, from now on, when we do the practicing, make sure you have a pen and paper, or like you can buy a small booklet for every scenario. Even if others are being grilled, you can write down their answers and the critique, the feedback. When we finish, we tell those, we tell you and we tell others, like, you should have said that, you should have not said that, blah, blah, blah. You write these down. Because when you come and revise for your exam, you can go back to this booklet. Okay? Yeah. So, and again, that will give you as well that, as Sumaya, you rightly said that, okay, I would like to write this and this. Yeah, I mean, they will tell you, this patient had a white count of 13, CRP of 400. You can still write these down. Or if your answer is ready, just shoot the answer. And another important technique is that you need to wait for the examiner to fully finish the question. Don't start answering before the question is finished. Before the question is finished. Yeah. All right. You need to finish. Take like 2 seconds. Take a deep breath. Think about what words will come from your mouth before you say anything rubbish. Make sure you organize what you want to say and say it out. Remember the buzzwords. Exactly what you did, Sumaya, earlier about duty of candor, never event. All those things are really important. Like what you just said, that, okay, this is an unwell patient. I would like to approach the patient according to CRISP protocol, sepsis 6. That's it. This is more important than probably the whole thing. This is a landing statement. It's very important. And this is what you said, Sumaya, quite rightly. Once you have said that, they are happy. They will not really keep asking you these things, because these are basically things that probably your registrar should have done them, or A&E should have done them. But once you have said that, they will immediately tell you, oh, okay, fine. Now the blood pressure is back to normal, not tachycardic anymore. She's stable. What would you like to do next? They will take the scenario slowly with you, but you should say it out, vomit it out. You see what I mean, Samar? Yeah, exactly.
Yeah.
So stable, okay, CT scan, fine. CT scan, okay, bang, they will give you CT scan straight away. Oh, I can see this and this and this. Okay, fine. What would you like to do next? That's it. The exam, believe me, Samar, you wouldn't finish this in 5 minutes. If you don't practice, you wouldn't finish it. So practice is really the key here. Yeah? Good. Yeah.
Thank you for clarifying that.
No problem at all. No problem. Anyone else? Shall we do one more to Muhammad, maybe, Al-Arabi? And when you call it a day? Muhammad, are you available? Muhammad Al-Arabi. Oh, probably he's slept. Safe, can you not log in with your phone? I'm sure your phone has a mic. I don't know. Right. Fine. I think they're away from their.
Maybe we should call it. Maybe we should call it an evening, because it's a good 2 hours. So thank you so much for the time.
Yeah, absolutely. No problem. So so let's see what we can do next in the future, and please, put your feedback in the group, how you think this gone, and so that would really help others as well to know about it. And I'll send the recording as well to others later.
Thanks, everyone. Have a good evening.
Problem. Thank you very much. Have a good evening. Thank you so much,
you.
Summer. Thank you so much.
Bye.
Have a good
Bye.
evening. Bye.